What is up? What is up, everybody? Welcome to another episode of the Insomniacs Livestream with your host, myself, Dr. Andrew Kim, MD. I'm a board certified psychiatrist. We do this live stream every Tuesday night and every Saturday night at 10:30 Central, 11:30 p.m. Eastern. And today's episode, we are talking about AI in healthcare, artificial intelligence, and specifically looking at aspects of AI in the healthcare field. And some of the topics we're going to be covering today are going to be things like just, some of the early successes and early implementations we've seen of AI in the healthcare field, some early emerging, like exciting advances we've seen, ranging from things like diagnostics to drug discovery, even just kind of the doctor patient interaction of advances they're making in technology with electronic medical record systems. And then we'll also just kind of talk about, and I want to hear from you, your own personal concerns about whether it be issues of privacy concerns about data and how it's stored, who has access to it, concerns about bias when it comes to training AI, concerns about accuracy and trust. Do you trust AI to be involved in healthcare or your personal healthcare, your loved one's healthcare? Do you see it as a great thing? And look, doctors are humans and they're inefficient and they make lots of mistakes. Their throughput is slow. This is a great thing. Who's responsible when it comes to errors related to hybrid AI doctor work? Uh, Disclosures. Do you need to be informed, and do you need to consent to allow the utilization of artificial intelligence um, when it comes to the use of AI in your personal healthcare? So these are the things that we're going to be covering today. So again, for those of you who are regular listeners and regular watchers of this live stream, I appreciate you joining, and for those of you who are new, welcome. And again, this is the live stream segment of my YouTube channel. We do this Tuesday nights and Saturday nights. So let's get started. First off, before we just kind of dive into healthcare related AI specifically, why don't we talk about just artificial intelligence and AI in general, broadly speaking, in societal terms, right? Outside of the scope of healthcare. And we'll get more specific. Look, whether we like it or not, whether you're for it, you're against it, you're excited about it, you have qualms about it, the reality is really mainstream business, mainstream institutions, and everyday society is heavily invested in AI. And whether you realize it or not, you are likely exposed to and utilizing some degree or portions of AI at this time. And proponents of AI feel like, look, AI enhances speed, efficiency, especially in industries that are laborious with repetitive manual heavy tasks, manual calculations, repetitive tasks. AI has the ability to crunch heavy duty calculations, complex computations. AI doesn't require, lunch breaks and bathroom breaks and, holidays. It could just keep churning as long as the servers and the electricity and the software is running, right? Um, so there is a lot in terms of things to be excited about, especially from a business perspective, societal perspective, when it comes to AI. And we'll give you some examples in just a minute. Now, those that are worried about AI are concerned about a numerous amount of things. One could be job displacement itself. When I said repetitive computations and calculations, things that are more objective, like it is quite possible that within the next decade, are we going to see a displacement of people in, I would say, non-complex accounting or tax, tax calculations, tax returns? Because look, at this point, I think all of us are familiar with things like TurboTax and all these kind of software-driven self-tax, submissions, which is already kind of software-driven itself. But with the sophistication of AI, definitely for your average everyday working person who doesn't have like 5 LLCs and S corp and all these things, right? Very easily, right? With the next iteration of AI, I mean, you can take something like TurboTax to the next level, right? And do you need kind of, your standard everyday accountant, right? I mean, obviously it can get more complex when you have living trusts and all these nuances, but job displacement is something that people are talking about. You have probably already seen, maybe you're already dabbling in software and apps online with AI generated, artwork, AI generated, text and writing novels and books and chapters, right? For example, look, I was just having fun with it, right? I mean, I've made a few YouTube thumbnails with AI generated artwork, right? There are even I was even dabbling because I was just intrigued. I didn't know people out there are already, putting out albums, literally songs and albums of music that are on YouTube generating tons of income. People are generating AI created music and putting them in iTunes. Some of these, you know, digital music catalogs allow AI generated music as long as there's no copyright infringement. And we've gone as far as AI software making sure they're avoiding copyright infringement, but allowing you to type with text, literally with text. You can type, "This is the style or genre of song I want. Maybe this is the hook or the chorus line, or just make one up for me. I want it to be this length. I want these kind of instrumentals to be highlighted. I want this style of voice, a female that sounds like blah, blah, blah." Oh my God. And it will generate a song in several minutes. I was impressed by some of the software I played around with. You can go as far as making what are called, voice modules where you record yourself maybe talking, singing a few chords or melodies, and then your voice could then be the lead vocal, and it will make sure it auto tunes, makes you sound very nice with just the right amount of reverb, and you could even be the lead vocal, in some of those songs. Um, so that's the insanity, right? Of how some of this could be used. I have some comments here. So Jenny says, yeah, I won't read this out loud for the sake of your privacy. Yeah, I appreciate you stopping by, Jenny, and trying to ask some questions. What I can't do, on my YouTube channel is I'm not your personal physician. It kind of crosses a boundary when I try to give people direct medical advice without knowing all the nuance, all the details about your case, and I can't be giving you direct medical advice. So if you had more generic questions about a specific topic related to certain aspects of your med questions, I can try to answer that in generalities, but I can't really get into the details of your specific medical case. And and I apologize, I'm not trying to be avoidant. It's just I can't. It's just there's boundaries with doctors patients relationships, and I can't really be giving you very specific advice of try this, try that, try this dose, try that dose, because I don't know the nuances of your diagnosis. There's a lot of nuance in psychiatric diagnosing, and I'd like to be able to give you specific advice, but if there's some general question related to something on your topic, I can try my best to maybe answer it as a general question later. But if you have one that you could phrase a little bit more generally without getting into the nuances of your specific case, that's the best I can really do. But I apologize, but that's just the nature of it. I get lots of emails and lots of messages about trying to give specific medical advice for each case. I can't really do that. So back to our topic here. Um, so people are worried about job displacement, that the creative arts arena is an area people are worried about, like musicians, artists, authors. What's going to happen when people, I don't know, people like me are bored and we're just using AI generated software? And is that what we want for society, right? Just kind of AI generated things that didn't really have kind of that, as corny as I sound, that spirit and soul kind of put into it with human sweat equity. So, um, you know, other things are, concerns about your privacy. Where is your data stored? Oftentimes, AI is trained by examining and studying human personal data, right? Our habits, our choices, our emails, what we browse, all these different things. Your data is power. Your data equals money, your data equals revenue. Why do you think these companies offer you free things like free Gmail, free Google? No, nothing's for free. Your choices and your habits and your predispositions, your behaviors, your demographics, and how those behaviors relate to them are all being studied, right? And now, if those kind of things are going to be used to train AI, does that concern you? Who has access to this? How is it being used, etc.? Biases in AI training, right? AI is only good as how it's trained and how it's programmed, right? And I know there's a concept of, yes, it can get better and improve, but there are concerns about biases in AI training, right? For example, look, there were even complications with like facial recognition data, right? I mean, it's come a long way, but earlier on, there were erroneous false positives. You know, people of certain color were getting false matches saying that this was the suspect, right? I mean, so there are biases in even how you train AI, right? There are ethical dilemmas. I'm going to give you an extreme example, probably a little bit facetious, but like, let's use an example of like automated driving cars, right? Let's say somehow, whether it's a hybrid of, the human itself was being irresponsible and then, semi auto drive or auto drive was kicking in, and then you're faced with two bad choices. They're just because of how wet the road was and how irresponsible you were. And, you might crash into this or you might crash into that, right? Or let's say we get as far as where it's like fully on auto drive, not just kind of these early forays into auto drive, but like full on auto drive. It's going to hit this or hit that. It's really, if the only choices are bad choice A and bad choice B, how have we trained it and how have we programmed it to say which bad choice is the lesser of two evils? It's kind of a subjective thing, right? So there are these ethical dilemmas about how we even train AI that can come up, right? So again, before we shift into healthcare specifically and healthcare related topics on AI, I think there's this misconception out there. When we say this word AI, people think about Terminator and Skynet and all these things. They're like, that's not going to affect me, or AI is a joke, it's a hoax, it's never going to come to fruition. And they think about robots and android babysitters, and they're like, that's far off. AI is not really even a thing, right? But no, look, if you think about it, AI is already embedded into a lot of the mundane things of your everyday life. For example, for those of you who are using Google Maps or some form of map app on your phone, typically they are utilizing or at least integrating some degree of AI software, right? Trying to in real time crunch and compute a lot of data about traffic patterns, accident reports, then factoring that in and trying to analyze your most efficient route where there are the least delays, et cetera, et cetera. So you are probably on a day to day, for those of you who are commuting and using these apps, utilizing AI and leveraging AI to some degree. So the other places, right? For those of you who order from Amazon, how many of you have not ordered from Amazon? Amazon has been kind of on, pioneering and using like AI robots in some of their warehouses, not all of them, some of them, and trying to find the most efficient ways to handle packages, collaborate with the other workers to make it more efficient when it can't do certain tasks, bringing it to them. But there are AI robots even used in Amazon warehouses to cut down on shipping times and delays in shipping times. Think about, how is it possible that you're getting a lot of these things in a day overnight? I mean, so they're leveraging AI even at an Amazon warehouse where you order probably a ton of your stuff. There's chatbots for businesses. Whether you like them or not, I mean, that's a different story, but chatbots are being utilized, right, by businesses. Even in agriculture, there are tractors, like John Deere has made smart tractors that can discern the difference between weeds and viable crops so that it can spray herbicides more, focused just in one area to minimize chemical exposure, to save money. Spotify, you're listening to music that AI is now driving and curating your playlist based off your habits. It tries to guess your mood, timing of when you have certain moods, etc. So Tesla has auto drive, modules and, modes on their cars. I mean, so this isn't something that's like this, way out there. It's going to only affect me 50 years down the road. I mean, you are having AI, whether you like it or not, involved in your mundane day to day life at this point. Okay. So now let's shift over. Let's get to the topic at hand, AI in healthcare, right? So again, let's not talk about theoretical. Have there been some early advances? Have there been some early signs of success leveraging some of those positives that the proponents of AI talk about in the healthcare field? Let's go through a few concrete examples that I kind of, jotted down for us to talk about. Google, of all places, right? Google's DeepMind AI software has, at least in some preliminary research, been demonstrated that it can identify ocular or eye diseases like macular degeneration, other diabetic related concerns that can actually match the accuracy of human, like leading ophthalmologists, eye specialists, right? It can analyze eye scans like optical coherence tomography or OCT scans. It could then make appropriate referrals for further workup. It can help then, basically enhance throughput for people who have, to get better access of care that maybe you wouldn't have gotten these referrals or early detection from. And basically, it can also summarize the concerns and what it's detected from its database of pattern recognition of recognizing eye diseases. And so the thought would be, could this be integrated, right, into your local optometrist office? Like, could they have these scans done at like Lens Crafters or wherever you get your eye exam and just use it almost as an early screener to catch things early before they go too far down the road, before they evolve and get more significant, to then make sure you get appropriate referrals to then go see, maybe an ophthalmologist or someone appropriate quickly. But it's insane, right? Diagnostics, right? Diagnostics is a possibility where they're showing some early successes with AI. I don't want to go down a rabbit hole with just diagnostics, but look, even with radiology, right? There are companies that are compiling, you know, multitudes of, databases with huge databases of scans to see if, AI can become efficient at identifying some of these, easier to detect, lower, risk diagnoses on radiology scans, brain scans, etc. Right? So uh, they don't get eye fatigue. They can leverage variations from tens of thousands, hundreds of thousands of images to use that as a reference point versus someone's anecdotal knowledge base of seeing, X amount of scans in their practice. So it's interesting, right? Obviously, there's still a ton of gray in diagnostics, and there's going to be judgment calls. And that's where some of the concern comes in, right? Can you trust machine learning and AI to make the judgment call in that gray zone? That's scary. I should bring my brother on here who is a radiologist. I should bring him on as a guest. I wonder what his thoughts are on the concepts of AI in the field of radiology. I should bring him on as a guest. Now, even surgeons are benefiting. Some of you who've gone through some significant surgeries may have heard of a surgical robotic system called Da Vinci, the Da Vinci surgical systems, where it's robotic assisted arms, and those have come a long way from their inception, and they've been around for a while. But now those Da Vinci systems that have already existed for some time and have already been assisting surgeons have now been integrated with AI software using real-time feedback to dynamically stabilize robotic arms to make very precise, fine incisions to assist the surgeon. I know, crazy stuff. We're looking at vital signs, etc. All these things to give real-time feedback. Obviously, the surgeon's still there, but it can actually assist in making actual precise incisions. It's insane. So surgeons are even benefiting from some upgrades to even existing tools utilizing AI. I think another area like mental health, here's an example in mental health. The idea of using self-driven cognitive behavioral therapy is not novel in itself. Okay. Those of you who are familiar with CBT or cognitive behavioral therapy, CBT is systematized and manualized enough that we have already proven that motivated individuals can utilize a CBT workbook or a self-help CBT workbook and still get some benefits, sometimes robust, to help bring their anxiety conditions to resolution, their depressive episodes to resolution. Now, is it always going to be successful and easy? No, of course. Or else I'd have everybody just go read a book, write a workbook. But certain individuals who are motivated and put in that time and work can make big gains even with self-driven CBT, cognitive behavioral therapy, even in workbook format. Then look, in the 90s, I would say more late 90s, early 2000s, then they came out with software-driven CBT, where, rather than having to read out of a workbook and do paper and pen exercises, it'd almost be like you would have this kind of robotic, software saying, here is your exercise. You'd do the exercise, fill in some feedback. How did it go? How stressed did you get when, with your fear of contamination, we asked you to then go, touch a dirty doorknob, and like, how did you react? You put in your things, but then, it gets a little hokey because you might have these predetermined canned responses, right? Because there's only so much that like non-AI driven software can do, right? Some decision trees of if you selected this, then this is just some if-then scenarios in a very black and white fashion, right? And then now there are apps, whether web-based, on a browser or on your phone, where in real time, it can with your feedback. Sometimes your feedback might be you interacting with the app. Sometimes it actually could be with a wearable. It's getting kind of crazy, where it can modulate and kind of be a little bit more dynamic with their CBT exercises. If it says you're depressed, you're stressed out today, it may pull back on how much it challenges you in your cognitive behavioral therapy exercises. Kind of, again, trying to fine tune it to where you're at dynamically, right? I'm overwhelmed today. I'm stressed out. I'm tired. I didn't sleep well last night. I'll say, okay, you know what? We're going to have you practice some relaxation techniques. We're not going to have you do these exposure techniques and have your tension rise. Let's pull back a little bit, right? I'm having a decent day. I'm feeling motivated today. Okay, we're going to take you up your next hierarchy of distorted thoughts. You know how you said you have these anticipatory worries that everyone's going to hate you, judge you, blah, blah, blah. So why don't you go find a stranger today at the grocery store, ask a question, say hi. Let's do that since you're motivated today. Boom, right? So dynamically kind of changing, right? Detecting from your wearable that your heart rate is high, that you didn't sleep well last night. Hey, are you feeling okay? Seems like you didn't get a lot of sleep. Your heart's pumping. Have you been making up for it with some caffeine? Or are you stressed right now? What's your response? And then adjusting your therapy exercise with that. It's crazy. So even in mental health, we're already leveraging at the direct to consumer level. It's not some theoretical pie in the sky. You can go check out some of the apps right now. And they're even utilizing this to do evidence-based therapies that are legitimate. Things that have been around for 70 years to help treat these disorders are now leveraging AI to, as KG says, Dr. Google ain't shabby. Now you might have AI therapist. AI therapist might not be that shabby. If we know that if we know that a textbook, like a self-help CBT workbook can help, and we know that it can help, why wouldn't a more sophisticated workbook, right, an AI-driven workbook in a way, I guess you could put it, why wouldn't that work even maybe somewhat better, in my opinion, when it has more of that nuance and real-time feedback, right? And Jenny, yeah, just stick around, bear with me. When we pause in a little bit, I'll answer some of your questions. And here's another example. Jenny herself says, at our family doctor, they ask if they can record the appointment so they can use AI to create notes. So this is not a futuristic thing. So what Jenny is referring to is now even major health systems. This is not just some boutique clinics that are just doing this for fun or to brag that they're a pioneer. Kaiser Permanente is using a software called Abridge, Abridge, and other health systems like they're testing it out at like Emory Health and all these other places. Big name systems are using AI driven software to listen to the entire interaction of the family doctor. Some of the more sophisticated places, I mean, the real cutting edge places, it's not just audio recording. They're using multiple camera angles. Literally, they have the exam room where you get examined by your family doctor with multiple cameras. Again, they need your consent. Are you okay with this? Right? You can't. KG, you are always funny. KG says, you can't spell Kaiser without AI. You are effing hilarious, my friend. But yeah, there's even places where, again, with the patient's consent, right? They're not going to do this for like an OB visit or something. You're, a standard physical where maybe they're just listening to your lungs even under your shirt with like a stethoscope. But some places are doing even more cutting edge stuff. It's not just the audio recording, but even with multi-camera systems and the AI integrated into audio and camera systems will say, patient Andrew Kim was dressed in a hoodie, seemed decently kempt, shaved, based off chest movements and shoulder movements, respiratory rate estimated at 14 a minute, based off the Bluetooth blood pressure cuff they use. Blood pressure is this. The audio recording, as Jenny was talking about, listen for keywords that the doctor or nurse practitioner is saying to the patient and the patient's feedback, and literally summarizes the encounter. Patient's main concerns was the fact that they were having heartburn, states that it was occurring for the last 3 weeks, tends to happen at night after eating heavy meals. Doctor recommended lifestyle changes as the first intervention. List those bullet points of what they heard from the doctor. If not, then please take these antacids. If not improved, then call us back, and then we'll ask you to take some pantoprazole, right? Bam, right? Is it perfect? No, obviously that's where still humans need to step in. The doctor needs to review it, make some edits, some grammatical or syntax errors. But man, I mean, it is really getting there. It is really getting there. And I don't know how it is. Jenny can comment here. The quality of, is it layperson friendly? Is it pretty accurate and summarizes what you did, in the room with the clinician? But I mean, from the examples I've seen, man, I mean, it's pretty fascinating stuff. Now, the hope would be, right, in a scenario like this takes away, I guess, how do you put it? The transcribing burden for the physician or nurse practitioner. So you can actually, for the 8 minutes saved, 10 minutes saved, and doing all that, you can then allocate that to actually talking with your patient that much more, right? Or instead of concurrently typing and being semi-distracted, because I don't care what anyone says, right? I'm a really good typer, actually. You're still multitasking, and you still can't give 100% of your attention to your patient. And I know, some docs, some colleagues of mine refuse to write on their notepads or type while they're talking to their patients. Say, I'm going to give them all my attention, and I'm only going to do this after they're done. And I respect that. I do. But they're probably in private practice at a cash-only practice where they can afford to have breaks between patients and write at their leisure. I'm sorry. That's just the truth, right? So when you're working as a salaried employee at a company, hospital, clinic, hospital, private group run by a conglomerate, I mean, you're going from patient to patient. Is that correct? And that's how it should be? No. But knowing that that's the system in which we work with, even though we should probably burn it down and rebuild it, in my personal opinion, this is a way where we can fight back a little bit, get back some of that time to then devote back to our patients with even more attention. So I see that as beneficial as long as we're not blindly just trusting everything's fine. There's still some human oversight. That's what's important. And finally, right, drug discovery is another concrete way that AI is being leveraged. And let me just show you, right? I want to show you an example of this company right here. Okay. See if I can enlarge this a little. Whether this is going to pan out and these will actually become, FDA approved or not is to be seen. But look, you can see that some of these are already in the phase 2 stages, meaning now you're at, you know, phase 1 is basically you're just giving this to healthy human subjects, maybe one dose, a couple doses, and you're seeing what is the absorption rate, what are the blood levels, what are the side effects, what dose ranges make sense to test in the next phase, and is safety and tolerability acceptable enough to move on to phase 2? Or phase 2, you are finally then answering, like examining the question, will this treat the disease or syndrome in question, right? And some of these have already made it to phase 2. So this is a pipeline chart of a company called In Silico Medicine. I believe they're a global company, but I think that their US base is like in Boston, possibly. And basically, AI is expediting drug discovery at this point. And a lot of pharma companies and startups are leveraging AI for drug discovery. So rather than, literally doing an insane amount of trial and error with like in vitro cell studies looking at cell stains under a microscope with a naked eye and having lab interns doing this repetitively and just, man, it's time consuming, cost consuming, labor intensive. They're basically having AI using heavy computational models, analytical models to see, number one, what are targets we should even be targeting? Number two, what types of compounds could be used? Can we even repurpose existing compounds? And what the crazy part is, again, leveraging AI, can we actually create novel compounds? And AI will actually try to generate novel synthetic compounds, theoretical ones at least, to see, since none exists in our database, let's make up a new one. And in theory, this might hit that target. Whether it'll pan out to actually help the disease or not, that's a different question. But they're actually even just generating AI-generated synthetic compounds that startups and pharma companies are deciding, should we pursue that as a synthetic compound that we should make as the next experimental compound to test? And they are shaving off so much waiting time, so much labor, cutting down timelines to get to animal studies, phase 1 studies, and now, as you can see from this chart, even phase 2 studies for crazy things, right? I mean, we're not talking about like, oh, we're trying to do this for heartburn, not to diminish heartburn. I mean, they're examining these things in idiopathic pulmonary fibrosis, specific cancers, COVID-19, breast cancer. I mean, crazy stuff. So again, this is, whether these will pan out, who knows? If one of these compounds pan out, that's a victory for AI being leveraged in healthcare, in drug discovery, because that is crazy. That is crazy. Okay. So we shall see. I think we'll have a better idea if this is just throwing spaghetti on the wall and, premature excitement, or if this is actually going to pan out. But just look at this pipeline. This is crazy, right? So these are the things, right? These are the things that, at least I can say, are early signs of AI being either already successfully integrated or at least showing some promise of what can be, right? And at the very least saying that this should be researched and funded more, integrated more. It's pretty fascinating stuff. Okay. Now, let's talk about concerns. And this is where I want you to pipe in. Are you excited, and do you see the positives, the possibilities, things we haven't even thought of yet that we should go full bore with AI integration into healthcare? Or do you have concerns? And when I say concerns, these would be some of the standard common fare concerns. I kind of hinted at the beginning. One of them that comes up quite a bit, not even just related to healthcare, but AI in general, like we talked about earlier, is data privacy and security. right? Even when we're relying on paper charts stored away in some dust cabinet, some old cabinet somewhere in a medical records department. I don't know which is less safe, I guess. I should assume that's safer, but I'm just saying, even right now, right? Even pre-AI, pre-cloud based, storage, PHI, private health information, and HIPAA breaches still happen, right? There's still privacy breaches, mistakes happen, health information gets leaked. It's a big deal, right? And now, what are going to be the safeguards, right, for the collection of sensitive private health information? How will it be stored? Who will have access to it? Will that data be used for more learning to train AI? Do patients need to consent for that? How safe are cloud-based storage, et cetera, right? All these different things, right? The concept of kind of what Jenny was referring to, right? Informed consent and transparency. Patients may not be aware that AI is being leveraged to maybe consider a differential diagnosis. Maybe it even helped give ideas for a plan. And right now, there is AI software that will generate, hey, based off these symptoms, here are suggested treatment options. But of course, asking the clinician to then decide if those are appropriate or not. But still, would a patient want to know that some suggestions were made to the physician or nurse practitioner from AI itself? Again, you could cut that both ways. Well, yeah, I'd want my doctor just to know, like, and not forget because he's having a tired day or a bad day, what all the options are. I would hope that he's ultimately going to be the decision maker of what is and what is not appropriate. So you could see that as a good thing, or that could evoke some concern and worries. Well, is this my doctor's thoughts? Or is this AI telling him these are some good ideas? He's like, let's roll with it. Or she's like, let's roll with it, right? I mean, so again, transparency. Are we going to get that much more explicit and demand our providers show you want to inform consent, that like you are consenting to allow us to leverage software to help us with differential diagnoses, to record your interview, to print out your summary notes, and knowing that AI helped dictate all this and type it out? Again, good or bad thing, right? What is the accuracy? Is it layperson friendly? Is it correct? Does it capture nuance, or is it very black and white? Of course, things will continue to advance, but would you have concerns about that? We talked about the concept of bias. Is bias going to be a problem? Who is training the AI? What information and databases are training at? Because again, garbage in, garbage out, quality in, better quality out, right? So how we are programming these things, how we are programming them to learn, it does make a difference, right? So who are going to be the watchdogs and the safeguards? What safeguards are going to be in place to ensure that even the training and the learning of AI is up to the highest standards, right? Uh, Accountability and responsibility. Let's say whatever, a summary has wrong information. A summary said something very offensive, hurtful to the patient. Let's say a doctor, nurse practitioner was overly reliant on AI generated suggestions or recommendations. Let's say a mistake happened. Who's at fault? Is it the health system that leveraged the AI? Is it that individual clinician? You consented and allowed them to use it, so they're going to get off scot-free. Again, responsibility, accountability becomes a concern, right? So, do you also lose the human touch, right? And I'll kind of end with that. So, mental health is tricky. So, I'm going to bring it back more personally to me to kind of close the loop. Then we'll go into some Q&A with you guys, right? Every field of medicine is great. Let me be real, okay? Even my mother is in internal medicine. There's still judgment calls, right? Is this white coat hypertension? Is this stress in their life causing the hypertension? Is this idiopathic hypertension? Should we focus on dietary changes first? How much time do we give them with lifestyle changes? Should we just intervene now with blood pressure meds? The number is the number. Technically, they have high blood pressure, but where do you make that? Where do you draw that line to be like, all right, I gave you enough time. Lifestyle changes don't seem to be working. Let's give you some lisinopril. Let's give you some hydrochlorothiazide for your blood pressure. Where do you make that call, right? That's what I mean. Every field of medicine has gray. Radiology says, I can't tell. It's definitely a growth. It's hard to tell if it's benign or this or that, but statistically, it's probably benign. We should go have you do a biopsy in the next X amount of months versus I want to be safe. Let's have you go get a biopsy now. I mean, there's judgment calls. And then now you enter the field of mental health. I'm not saying mental health is special because I just illustrated gray in every field, right? But there's so much gray and there's so much nuance in the field of mental health, right? Not every person's presentation of anxiety is the same. The end manifestation might be I'm struggling with chronic anxiety, but do you have chronic anxiety because you have generalized anxiety disorder? You're anxious chronically, but you're functioning rather fine. So it's causes some distress, but it's not causing impairment or dysfunction per se. So is it really a disorder? It's bothersome. You have anxiety because you're chronically going in and out of mild alcohol withdrawal. You're anxious because of complex trauma and PTSD, but anxiety is partially how that manifests because of trauma effects. Right. I mean, there's autism, and because of the autism, you're struggling with anxiety in social context. Anxiety is a non-specific end manifestation. And how does AI kind of grapple with that? Right. And again, other fields they're not immune to it. I'm just saying, God, it gets so murky in the field of mental health and psychiatry, right? So I just wonder what the role of AI will be in the field of mental health. Again, it's not even from a fear factor. I don't think I'm ever going to be replaced. I really don't. It's just, where can we actually leverage it to be helpful and not just become more white noise and something that causes more burden to a patient physician dynamic versus helpful as a tool, right? So we shall see. But bottom line, what are your guys' thoughts for those of you who are here or those of you who are hearing this as a recording, not on the live stream? When you think about some of the topics we talked about, some of the theoretical concerns versus some of the excitement, some of the early successes, are you like, let's do it all in? AI seems awesome. AI can only help. AI, it will augment the human clinicians. Let's do it. Or want it in a moderate dose, feel like we need better safeguards, we need better transparency for patients' rights. We should catch up with those things before we go full bore. Or hell no, keep that away from me, right? So leave your comments for those of you who are seeing this on a recording. And anyone who's still around, why don't you chime in here? So now that we have some time, we'll open it up to Q&A as we're wrapping up. So Jenny, let me answer your question. So your earlier question, if you're still here, it says, have you seen NRIs work when none of the SSRIs have worked? What do you think about ketamine? And are you accepting patients? Well, the patient one is short. I don't have a private practice, so I don't take any private patients on the side. I work for a telehealth company. Our company works exclusively with colleges and universities. So right now, I'm only seeing, not only, I'm seeing, I have 51 licenses. I'm seeing patients across the entire US, but they need to be at a school that happens to have a contract with us. So we don't bill insurance. Interestingly, we have a very unique model where we contract directly with the university and college. And if you attend that school and they have our services, patients don't pay copays, doctor's fees, just pay for their own meds on their own with their insurance. But I'm only seeing patients through the company I work for right now. And seeing patients that are at undergrad, grad school programs, nursing schools, dental schools. We work with like 400 schools, but about like half of those have psychiatry services with us. So I'm seeing students at like 200 schools. So no, I'm not taking any private patients at the moment. To your other questions about general medical questions, again, I'm just answering this in general, not for your specific case per se. But yes, I have seen patients who have not responded to SSRIs, but then will respond to a SNRI. Um, in general, if I make that switch for a patient of mine, you know, again, this is a preference thing. There's no evidence that one SNRI is better than another SNRI. So I'm going to preface it by saying that there is none. Okay. Anyone who says that probably just has some personal opinion on it or bias or whatever. Maybe, you know, they're wedded to one or have some relationship with a company or something. But systematically speaking, with meta-analyses, like there isn't one SNRI superior to the other. I think the things that you just have to figure out is each person is so different when it comes to tolerability and side effects. Uh, it will take some trial and error, and that is very frustrating. But there are SNRIs that exist pre 1980s. Those are called tricyclic antidepressants or TCAs. And then 1990s onward, there are several. There's like venlafaxine, which is Effexor, duloxetine, which is Cymbalta, milnacipram, which is Savella. There's several SNRIs. Now, the only preference, I mean, again, it's a preference thing. Not saying one is better than the other, but if you follow my logic here, between some of the newer ones, I just picked the generic ones because most insurances cover them versus some of the fancier, newer SNRIs that are brand name. And really, there's no need to do that because they're expensive. You're going to need a prior auth. You probably can't even access them. So with the generic ones, it really kind of boils down to venlafaxine, which is Effexor, and duloxetine, which is Cymbalta. And I tend to lean towards trying duloxetine first, not because it's better, but just to explain. Venlafaxine, you typically start patients at 75 milligrams. That's like an introductory dose. You then go up to 150, maybe a week or two later, once you've established the intro dose is tolerable. 150 is the minimum therapeutic dose for the average adult. And that's, again, a general statement. If that dose doesn't work and you don't get a response or remission in 6 to 8 weeks, you then, if tolerable, go up to 225. So theoretically, you're going to be testing one or two doses at 6 to 8 weeks apiece. If you don't get better at 150, you try 225. The one comment I have is venlafaxine tends to be what is called a dose-dependent SNRI, meaning at the lower doses, 75 to like 100-ish, even maybe 150, some can argue, it's a little bit more like an SSRI, and you get a little bit of the norepinephrine action. And it's really at like above 100, maybe 150 and above. I would say above 100, but like, 150 and above, definitely when you're at the highest dose, 225, then it starts functioning more like an actual SNRI. So interestingly, like if you ever had a physician who was like, let's put you on a SNRI to change it up, and they only kept you at like 75, I'm not saying there's no norepinephrine action, but there's not much. So in essence, you're almost getting an SSRI. And did you actually then try something different? I would argue not really. Okay. But that being said, the reason that I personally prefer duloxetine between the two when I start someone on an SNRI is duloxetine, the goal is to get you to 60 milligrams. And depending on the adult, some of them, if they don't want to slow things down, it's not absurd to just start them at 60 milligrams. You could just start people at day one at 60. Now, out of conservatism, oftentimes I would say for some folks, start them at 30 milligrams, but they'd be on 30 milligrams for 1 week, maybe 2 weeks at most, and then go up to 60. But that's it. That's the main dose you are testing. So unlike the venlafaxine, where you will test either 150 or 225, you're just going to kind of test out the 60 milligrams. And once you're on 60 and you give it 6 or 8 weeks for depression or anxiety, you kind of have a sense of, hey, it's worth it. You're getting a robust improvement, or it's not. And now maybe you should just move on. So there is like a time savings component theoretically by using that, because you're not testing multiple doses, you're testing one dose. Okay. And I try to think of it from the patient perspective, right? You might luck out, and maybe at the first dose of venlafaxine at 150, maybe you're going to get much better. But in case you don't, and you might have to test out 2 doses, I'd say, look, then I'm going to look at it from a patient's perspective. I'd rather test out 1 dose than 2 doses and save myself time. So you got to think of it from the patient perspective. And that's why I kind of do that. And then the other thing is, again, this is a little bit more theoretical and esoteric, but I kind of went through that whole venlafaxine functions differently at different doses. Duloxetine is just kind of an SNRI at any given dose. So you kind of get that dual action confidently, whether you're at 40, 60, 90, 60 is the goal dose. And, that's why I just am confident you're getting an actual SNRI mechanism at any given dose and 1 dose to test. So I know that's kind of rudimentary logic, but in the grayness of psychiatry, that's the logic I would apply to try to save some time, cut back on waiting for patients who are waiting for a response. And that's kind of how I do it. Okay. Your other question, finally, what do I think about ketamine? I've talked about it before, so I'm not going to belabor it. You might have to find some of my older ketamine videos. And I do have ketamine videos. Ketamine is effective. It's not a wonder drug. It's not perfect for everybody. I want to give you full disclaimer. I say it all the time. It's usually in my info notes that, I no longer am, but even as recently as up till the end of 2024, I used to be on the Johnson & Johnson Speakers Bureau speaking about S-ketamine, or the nasal spray version of ketamine. But I also have a brain. And no one here on my channel has ever heard me say that ketamine or S-ketamine is a wonder drug and it's perfect. I've talked about the side effects, the logistical burdens, and the headaches. So I give a pretty fair and balanced presentation. The reason that I was on the Speakers Bureau is not just to make a quick buck. Yeah, they pay me when I speak and educate people on it. But I was one of the actual clinical researchers, the principal investigators at a research center that worked on the nasal spray ketamine trials, or S-ketamine trials, to get it FDA approved for treatment-resistant depression. So I have firsthand knowledge. I actually had my hand in the mix to help get nasal spray S-ketamine FDA approved for treatment-resistant depression. And I was also involved in the studies that used it for major depressive disorder with patients who were suicidal. The inpatient version of the studies, where we recruited, it sounds nuts, but we recruited suicidal patients. We actually looked for and were looking for suicidal patients to test this on in an inpatient setting. And that did get FDA approved for patients with MDD with suicidal ideation or behavior. So it has 2 FDA indications. And apparently recently, I'm pretty surprised, we should probably do a video on this, it finally got FDA approved for monotherapy. Prior to this year, or prior to recent months, it was FDA approved to be used as an add-on, to be used concurrently with an FDA approved antidepressant, meaning you're supposed to use nasal spray as ketamine with Prozac or Zoloft or Lexapro, whatever. Now it actually has FDA approval for monotherapy, meaning you can just use it on its own without concurrently having to take an SSRI, which is an interesting evolution, because I wonder what that's going to do to the hoops that people have to jump through, right? Because they'd make you do so many different meds, prove you did therapy before they were going to even cover it. But now they're actually approving it for an indication for treatment-resistant depression for monotherapy, meaning you can be on it alone without having to be on SSRIs, which is fascinating. But yes, to your original question, I know that was a lot of long-winded context. Yeah, it is a viable option because it is one of the first, and I'm lumping them together, IV ketamine and nasal spray S-ketamine. It is really one of the first novel breakthroughs in, I would say, over half a century. Because if you really think about it, Jenny, we had MAOIs, okay, which messes with dopamine, serotonin, norepinephrine. That's been here for over half a century. We've had tricyclic antidepressants in the 1950s, 60s, 70s. Those were SNRIs. Then we evolved to SSRIs, like in the 70s and 80s, like Luvox, Prozac. Then we circled back and we cleaned up tricyclics, for lack of a better term. And then there was a new generation of SNRIs. So we've just been like recycling variations of serotonin, norepinephrine, dopamine modulating meds. So we call that, those are called monoamines. And we have been working under the monoamine hypothesis for like a century. Finally, ketamine is breaking the mold. It's not perfect, but ketamine is thought outside the box. They said, there's more to this than just monoamines. What about glutamate and GABA, right? Glutamate and GABA and the interplay between those two. And now we are very focused on glutamate and GABA modulating drugs. We have ketamine and esketamine. We have that postpartum drug. Oh my God, I don't know. I hate how they named it. Zulresso and Zurzuvae, made by Sage Therapeutics. We have Auvelity, which is bupropion or Wellbutrin mixed with dextromethorphan. We talked about that before. It's meant to purposely prevent dextromethorphan from being digested. And by keeping your levels of dextromethorphan high, you will get a glutamate modulating activity, trying to almost poor man's version of trying to mimic ketamine is the best way I would describe it. Okay. So it's interesting because now this is where the field of TRD depression research has shifted to. But yes, to your question, viable option. Other viable options for TRD, low doses of certain antipsychotics added to, the antidepressant, TMS, which is transcranial magnetic stimulation, ECT, electroconvulsive therapy. Those are other viable interventions beyond your normal scope SSRI. Adding a little bit of lithium, even if one doesn't have bipolar disorder, is viable to try as well. So there's plenty of things. So there is not necessarily a lack of options. It's really more about how much trial and error can you endure, what side effects are tolerable, and logistics and cost and access, obviously, right? Those are all sadly factors as well. I wish that was not the case, but this is America and our healthcare system is screwed up and some of those treatments are hard to access for people. But bottom line is there is not a lack of options. I know it's easy for me to say because I click buttons and I send prescriptions and recommend things. It's the patients themselves that have to put their hope, energy, time in each one. And if it doesn't work, it just adds to the frustration and it adds to the discouragement and dejection. But at least as a comment of hopefulness, Jenny, there are many options. Even though you have tried many, right? And you mentioned lithium, so that one's off the board, right? There are many options that you have not tried. Okay. So there are things that you can do. Okay. And again, I'm speaking generally, but for anxiety, right? Sometimes you can augment traditional antidepressants with something called buspirone or Buspar, right? That has a different mechanism than SSRI. So there's a variety of things. Obviously, again, I can't go too in depth because I need you to be my patient and I need to give you specific recommendations, but talking in generalities. But hopefully that touched on some of the questions that you asked earlier. So I'm sorry I made you wait, but I didn't want to interrupt the flow of the live stream here. But okay, but let's wrap it up here. I'll give it a few more minutes. There's several viewers here. We had more people join. We were talking about AI in healthcare on tonight's live stream, but right now it's open Q&A. So it could be about the AI topics. It could be about anything in general. Going to give you guys a free for all for about a few minutes here before we wrap it up. If there's no lack of interaction, we'll just shut it down for tonight and pick up on Saturday with the next live stream. So last call for last round of questions. So, oh no problems, Jenny. I'm not trying to be difficult. Just, you know how it is in America. And I know it doesn't sound like you're the type, but it's just, I give some specific piece of advice, and then in America, people will just come after you, and then someone's going to file a lawsuit after me saying I gave someone direct medical advice, and they didn't have a bad outcome, and I said something out of context, and it's just so dumb. But this is the reality we live in, Jenny. I'm not trying to be difficult with you, so you know. But no, I hear you. I hear you. It's hard. I mean, you think this isn't just some dog and pony show. When I talk to my patients, I always have that discussion. I'm like, is it worth this to you? Is it worth it to you? Because man, to put your hope and energy into the next treatment and the next treatment, it feels like a merry-go-round. And I have to sometimes stop and pause and say, hey, like, do you need a break, and should we do some other like non-medicinal things, right? So it's hard. We can't lose the human touch when we work with our patients. So KG says, do your patients do okay with AI transcription for your appointments and sessions? Well, for us, my company right now, we don't allow AI to be integrated for transcription, so we don't do that. So I'm still doing the old-fashioned, using templates, typing it in manually. So it's something we've been talking about, but yeah, we would have to really get into probably the consent process, a very transparent consent, saying people are going to be like saying that you're okay with us having that transcribe some things, right? So so that part I would be fascinated. You tell me, KG, are you okay with AI listening in, maybe going into the cloud on a web-based platform to like use processing to then throw out stuff? You tell me while I look at the next question. Ray says, what's the topic for Saturday? I don't know. I'm a very disorganized person, Ray. I really wish I was more organized and I can even put these live stream bookmarks and placeholders sooner. I know you've mentioned before some things about benzo, like prolonged withdrawal. I haven't forgotten. You tell me though, Ray, what are some things you might want me to look at for some possible topics for Saturday? You tell me before you log off tonight. Give me throw out a few, and I can see what resonates with me as a topic that might be a little, got meat to its bones that I could talk about for at least 30, 40 minutes. So give me a few suggestions, even if it was one that you mentioned before. So why don't you do that? But yeah, you tell me, KG, what are your thoughts about AI being involved in any aspect of your personal healthcare? You're cool with it. You're cool with it as long as people are transparent about it and you consent to it. You don't care. Just just get it right and do right by me. I mean, what's your own personal attitude, KG? I'm just curious because you've always been pretty transparent and straight and blunt about things. So what's your take on it? So last call for questions. Let's do last couple minutes here while KG hopefully responds to me. Any other last minute questions? So Ray says prolonged withdrawal syndrome. Okay, prolonged withdrawal syndrome. Okay, I can try to dig into that a little bit more. KG said my PHI is an open Facebook. Okay. Gotcha, KG. Got it. KG, where are you from? I'm not trying to dox you or something. Where are you from? Because I know some of the folks here, like I know, was it Lisa was from the Northwest in Seattle, and I've had some people, I forget the other gentleman's name who's from New Zealand. Where are you from, KG? Which part of the country are you at, out of curiosity? Here in Illinois, apparently we're going to get bombarded with snow tomorrow night. So my son was ecstatic. He's getting early dismissal from school tomorrow to avoid the bad weather. I think I was surprised because it's not like a ton. It's like 3 to 6 inches. I mean, it's a decent amount, but for Illinois standards, that's not a ton, crap ton. I mean, when it's like 8 plus, then I'm like, all right, this is going to suck shoveling. But I'm surprised they're doing early dismissal tomorrow. So I got to be Johnny on the spot and try to get off of work on time so I could spend some time with him. So, but okay, last call, going once, going twice. I appreciate you guys, especially the regulars. Thanks for hanging in today. Sorry for the late start. I know I started a little bit late. Trauma and treatment. Okay, Ray, thanks for that. Trauma. So trauma like PTSD, complex trauma. looking at things like that. Hanging in the Pacific Northwest South. Okay, cool. Cool. Very nice. Okay, yeah, I could. Yeah, let me look at both. I'll look at prolonged withdrawal. I'll look into trauma and treatment. Let's take a look at both of those topics, and I'll see which maybe I can integrate one of those into. Let me write that down right now so I don't forget. So, prolonged withdrawal. Yeah, you know, outpatient alcohol reduction strategies. Okay, yeah, we could. Yeah, maybe we could do a double, right? We could talk about withdrawal strategies, but also then piggyback that into prolonged withdrawal. Yeah, we could do that. We can do that. Maybe we'll just do that. That sounds so, because that kind of naturally flows together. So, alcohol. All right. So, making note to self, putting a sticky note on my screen so I don't forget, literally on my computer screen. No, we could talk about, so that might just flow well together, and between the two topics, that could constitute a long 1 hour session where we could talk about that. Yeah, and you know me, I'll give you my no BS assessment on some of the options that are out there. Yeah, but trauma itself could be a whole hour long thing. So yeah, these are good topics. So yeah, maybe this Saturday we could do outpatient withdrawal, alcohol withdrawal strategies, benzo, which because they're very similar. So alcohol/benzo withdrawal strategies, prolonged withdrawal data phenomenon. We could talk about both, and then maybe we could do trauma. Next week. Yeah, there's so many angles we could do for trauma. We could talk about different therapy modalities, thoughts on EMDR. I don't know what your thoughts are on EMDR. I have thoughts that will piss off a lot of therapists, and it's not a like psychiatrist versus therapist kind of thing. It's just I have very, I don't even know if to say outlier. I think a lot of colleagues of mine, both in therapy and psychiatry, have very strong thoughts about EMDR. We just don't want to say anything because you're going to get ostracized and criticized as being like, you don't want to help trauma patients. But no, it's like, I don't want trauma patients to be ripped off. But yeah, I'm not against EMDR, but I actually don't think EMDR is unique or interesting, honestly, because we've already done several studies to show that EMDR doesn't really need the eye movement portion, because what's integrated into EMDR is you're basically doing a proven commodity strategy called exposure therapy. Literally, you're doing exposure therapy, which is a proven treatment for PTSD or complex trauma. And throwing eye movements and eye stimulation with lights into it, I'm sorry. My personal opinion is it's just a way for people to charge more money. I'm just gonna say it. There's literally minimal objective data that is required for the outcomes you get in EMDR. I'm just gonna say it. It's just but we could get into that. It's people get so pissed when I say that, but I'm just telling you the truth. I'm an evidence-based person, and you could show me all these random journals and stuff. We'll see EMDR works. Yeah, well, I don't know. So, yeah, see, no, systematic desensitization. Yeah. So, all right, guys. Well, thanks for hanging in, and I appreciate you guys. Thanks, Ray. Thanks, KG, especially helping me shape the next episode. We will do some outpatient withdrawal strategies. I'll delve into some of the depths of some journals and stuff, prolonged withdrawal syndrome, and we'll have at it. So hopefully at least the two of you can attend because it'll be pertinent to topics you suggested. And we'll talk then, guys, and we'll see what other newcomers or other regulars join us on that day. You guys have a good night. Stay safe if it's cold and snowing in your regions, and I will talk to you guys on Saturday. Have a good one, guys.